Good evening and welcome to another episode of Fresh Natural Live. It is Monday evening and we have a great show lined up for you tonight. Today has been somewhat of a busy day, a lot of administrative stuff, some clinical work for me today, and of course, getting ready for an awesome show. It's going to be somewhat of a quick show. This is a topic I wanted to discuss maybe a few weeks ago. There's a recent publication in the Journal of American Medical Association, JAMA, that talked about the all-time risk, or I should say absolute risk reduction in use of statin drugs in people with cardiovascular disease or risk factors thereof. And I thought it was an important study to look at. And what I want to do is talk about the use of statin drugs, the treatment of cholesterol, elevated cholesterol and heart disease in the context of treating elevated cholesterol in light of this study. So there's some important information here. There's a little bit of technical data that is that I'll share with you in the study, but I'll break it all down. So I think you're really going to enjoy this topic, as I think you enjoy all of our topics. And what I want to do is, discuss the science, bring you some translation of the science and apply some practical applications so that you can become better informed. Those of you who may be taking statin drugs or may be offered statin drugs by your physician, I think it's important to get an understanding of totality of the use of this medication. And we may even allude to the context of taking any medication and absolute risk versus relative risk. So stay tuned. We have a great show tonight. I'll see you on the other end of the intro. Welcome back. So we're going to be talking about a study published earlier this month in the Journal of American Medical Association. And it talks about the difference between the absolute risk reduction of using LDL lowering drugs, i.e. statin drugs, compared to the relative risk for reduction of things like heart attack, stroke, and all-cause mortality and relative risk. To kind of differentiate the two, all-cause, absolute risk kind of puts everything in the barrel. In other words, what's the absolute risk if you have one population of people on, say, said treatment and another population of people on who are not on that treatment? The absolute risk, by and large, takes in account of the benefits in terms of reducing specific abnormalities that treatment is designed to reduce, i.e. if treatment A is designed to reduce your risk of having, say, a heart attack or dying from a heart attack, then you look at that, effect, but then you turn around and you look at the total population effect. What's the absolute risk? Now, it's hard to measure, the global absolute risk of a drug when you just look at one study. One study could be biased in a certain way. So oftentimes scientists, epidemiologists look at multiple studies. And that's called a meta-analysis, multiple studies that are designed in similar fashion that look at similar therapies and similar outcomes. And so when you look at a meta-analysis or look at multiple studies, in theory, you can, to some extent, theoretically correct for potential biases or errors or shortcomings in, say, one said given randomized study. Plus, you are pooling the numbers, and so in some way, you're increasing the power of that particular analysis that would then give you, more information. And so it's probably the power increase or the ability of that study to show a true outcome as opposed to a random outcome is also the potential benefit. So when you want to look at absolute risk, you want to say, okay, how is it this treatment going to make me do better overall? Is it going to improve my survival overall, in addition to just reducing my risk of a heart attack, or reducing my all-cause mortality from heart attack, stroke, or cardiovascular events? Is it going to reduce my overall risk? Or there are other potential problems with this drug that's going to create another problem that's going to make me sicker? And so we want to look at this, number one. Number two, I'm going to look at a particular study called the Jupiter trial that looked at a particular statin drug. And we'll look at an example of how this particular risk analysis can be made. So you had the Jupiter trial, which looked at the reduction of cholesterol and inflammation, and it showed an all-cause mortality reduction in cardiovascular events. But then they also looked at, absolute reduction, and there was a difference there. And so it lines up with what was published in JAMA. And then what I'm going to do next is then talk about other treatments and other ways of lowering your cholesterol that are more natural approaches. And I'm going to share with you some of the data that we've had in our studies in terms of not only reducing cholesterol, but reducing inflammatory markers and reducing other things. Because when you're looking at cardiovascular risk or risk of cardiovascular mortality or cardiovascular events, you have to look at more than just cholesterol. And some people argue that cholesterol is probably less important than other biomarkers. And I'll share some of that information with you. That's one. Two, also, you have to think of when you're providing a certain treatment, you have to look at it from two sides. We often look at it from one side where this treatment is causing a potential beneficial effect, say, for instance, reducing cholesterol, reducing inflammation. And so that's a good thing. We say, okay, well, it's reducing cardiovascular events, but then is it causing some other problem that may not be easily detected in one randomized trial or for a certain duration of evaluation? So that other adverse event can linger over a period of 5, 10, 15 years. And so, maybe you're not having a heart attack in the next 5 years, but there may be some other organ system that's being damaged. And so the overall benefit is being canceled out. So the risk of heart attacks being canceled out because you're getting sick and dying from something else as a result of this treatment. So, I want to kind of share that with you. So let's get into some of the data. I don't have my pretty PowerPoint slides, but I have the actual articles here. And so what I want to do is just go through this fairly quickly. I only have the abstract. I wasn't able to pull the full article. There was some problem with the JAMA's site. But essentially what they did is they looked at is a meta-analysis of 21 randomized control trials. So randomized control trials are theoretically gold standard trials. So as most of you know, many of you know, when you do a randomized control trial, you say, okay, we want to ask this question on a stage, evaluate this hypothesis. And in this case, we say, okay, let's look at the benefit of this statin drug in having this outcome. You have usually look at a primary outcome and then secondary outcomes. And then you analyze the data and see if anything else comes up. So in most cases with statin drugs, they look at the primary outcomes may be reducing cardiovascular events, heart attack, stroke, hospitalization related to those things, or they may have look for reduction in cardiovascular mortality. And then secondarily, they may look for reduction in morbidity, which would be events and hospitalization for said events. So a randomized trial, you start off with a group of people that are similar age, well, there are two groups that are divided randomly so that you get, similar age groups, similar morbidity to mortality in each arm of the group. And then you give one group the therapy and one group placebo, and you follow them over time. And then you look for these events. You measure biomarkers and other, clinical markers that may give you clues to the mechanism, et cetera. So you have a randomized trial that may do that. In this case, this study looked at 21 such randomized trials. So, typically these trials may have anywhere 20,000 people in them, something like that. So you look at 20 of these people have 400,000, 500,000 people in this population. So that gives you a large number of people where it's powered to look at the study. So this meta-analysis looked at publications of these randomized trials. So what did they find? My highlighting wasn't saved here, but that's okay. It's not a problem. What they found in terms of, and this is a lot of technical terminology here, and I'll highlight as we go, but there was a significant heterogeneity, a significant difference between the absolute risk of 0.8% for all-cause mortality, 1.3% for myocardial infarction, that's heart attack, and 0.4% for stroke. So there was an absolute risk reduction of these numbers. But that was much smaller than the relative risk of these same events when you look at the same population of people across meta-analysis. So a big difference in terms of the overall risk compared to the relative risk when you're looking at a smaller, looking at these studies individually. A big difference between 0.8% in all-cause mortality from cardiovascular events compared to 9%. So the absolute risk or the absolute benefit from taking a statin is much smaller than what you would look at if you look at these individual studies and look at the relative risk. And so the key here is to take this into consideration when you are looking at taking one of these drugs for treatment of your high cholesterol, or for prevention of heart attack, or for improving your overall cardiovascular side effects or risk factors. So in conclusion, they say the results of this meta-analysis suggest that the absolute risk reductions of treatment in statins in terms of all-cause mortality, myocardial infarction or heart attack, and stroke are modest compared to relative risk reductions. And the presence of significant heterogeneity reduces the certainty of evidence. So there's a reduction in how certain we are in terms of the overall benefit of these drugs, given this much smaller reduction in absolute risk compared to reduction in relative risk. Let's look at a particular study called the Jupiter trial. And this is a study published in 2008. Some very famous people here. Two of these people are trained under Dr. Antonio Gatto, a well-known lipidologist. I trained under him at Baylor College of Medicine. He was chairman of medicine when I was there. James T. Willerson was chairman of medicine, chief of cardiology when I was in my cardiology fellowship, University of Texas Science Center at Houston. Very big name guys here on this publication. So they were part of this major study where they looked at 17,802 patients. So this is a randomized controlled trial. And the background, the hypothesis was, well, the C-reactive protein, this marker for inflammation, is associated. We know it's associated with increased cardiovascular risk just by having increased inflammation. So the thought is, can you reduce C-reactive protein in people with relatively high C-reactive protein, but relatively low total cholesterol levels? So that was the essence, the backdrop of this study. So what did they do? They looked at 17,000, so a large number of patients, men and women, relatively healthy with LDL cholesterol levels of 130 milligrams per deciliter or less. They saw a C-reactive protein levels of 2 milligrams per liter or higher. Less than 1 is typically what you want your C-reactive protein levels to be. The LDL cholesterol, we typically shoot for less than 100 milligrams per deciliter. Sometimes people may not treat at between 100 and 130, but you typically want it so at 100 or less than 100. So you may enter aggressive lifestyle modification. But they gave these patients statin drugs. So their primary endpoint was heart attack, myocardial infarction, stroke, arterial revascularization. So somebody needing a stent or bypass surgery or hospitalization for unstable angina, or death. So these were the major things we looked for. There was a median follow-up of about almost 2 years, maximum 5 years. So on average, people follow up for 2 years. And the median follow-up time is really the time I look at. So that's the duration. I mean, you may have had, 5% of the people that they've been followed for up to 5 years, but you really want to look at the median duration. So these people follow for essentially 2 years for the group. And so what did they find? The rosuvastatin reduced the LDL cholesterol by 50%, and it reduced the C-reactive protein levels by 37%. Now, that was over 2 years. I want you to put a pin in that 2-year reduction in LDL cholesterol and inflammation. And so what they saw was that there was a 0.45 and a 0.85. So it's a hazard ratio, combined endpoint of myocardial infarction, stroke, or death from cardiovascular causes, and a 1 and 2. So this is a 0.45 and 0.85. So now this is the treatment group, and this is the placebo group. And here you have the treatment group, placebo group. So there was significant reduction, a hazard ratio in the heart attack, revascularization, unstable angina group of about 0.53 or 47. The way you read this is that the 0.453, that you took 1 minus that, that's 47% reduction. So if we go back here and look at these numbers, I'm going to walk you through this. The rates of primary endpoint were 0.77, 1.3 per 100 years of follow-up of rosuvastatin and placebo groups. In other words, there was a 0.77 per 100 years follow-up in terms of primary endpoint, and in the placebo group is 1.37. So if you look at the hazard ratio for rosuvastatin, it was about a 44% reduction. Okay, there's a hazard ratio of 0.56. And if you look at it with myocardial infarction, hazard ratio of 54% reduction. For stroke, and this is the range, hazard ratio of 0.52 or 48% reduction with stroke. And then the total you had combined for revascularization, unstable angina, hazard ratio of 0.53 or 47% reduction from the standpoint of revascularization, unstable stroke. So when you combine these, you had a hazard ratio of 0.453 or 47% reduction in myocardial infarction, stroke, death, and cardiovascular causes. But when you looked at death from any cause, there's about a 20% reduction from death from any cause. So in essence, you saw a significant reduction in LDL cholesterol, about 50%, and also a significant reduction in inflammation, which correlated with significant reduction in cardiovascular events and also stroke, heart attack, etc. Now, if you look at the study, so this is great. These are great findings. But again, as I said, if you look at a meta-analysis and the numbers are much bigger, you look at an absolute reduction. So what's an example of what could have an impact on absolute risk as opposed to relative risk reduction? Well, I'm going to show you, because in this very study, we learned something that I think perhaps people may have been suspicious of before, and I'm going to cut through this. And I gave you the title of this study if you want to look it up and go through it yourselves. This is going to be a brief show tonight. I don't intend to go and do a detailed analysis of this study. I probably will do a detailed analysis of this study and some other statin drugs on another show. But what else did they find? So other things, remember I said we talked about things that we find. We look for primary endpoints. We say, okay, we want to see if this drug has this effect. Does it reduce heart attack, reduce stroke, reduce death from these events? And then we collect data and we analyze patients over time and we see what else shows up. So in this study, what else showed up? Well, adverse events in general, there were usual adverse events, myopathy and various other things. But one thing they found was physician-reported diabetes was more frequent in the rosuvastatin group, 270 reports of diabetes versus 216 in the placebo group, and that reached statistical significance. Now, they weren't looking for that in this population. These events were not adjudicated by the endpoint committee. The point is, here was an interesting finding that was not a trivial finding, and this is something that raised an eyebrow. But the reason I point this out in this study is that, this is a randomized controlled trial. Here's a finding that you say, okay, here's what we found, and this was an abnormality. But if you got this study and you multiply it times 20, this finding of diabetes could also be amplified. And so small adverse things, maybe, liver dysfunction or various other things, can be amplified in a meta-analysis. And that's where you can have a blunting of the effect, looking at absolute risk reduction compared to relative risk reduction when you have these, other events that show up. So again, the hazard ratio showed strong benefit for rosuvastatin in this population with increased C-reactive protein. But a caveat is that there was an increased report of diabetes in this group. Let me just quickly give you an outline of the side effects of statin drugs, because, again, we look at morbidity to mortality. The morbidity side could be, nuisance side effects. So there are side effects that are asymptomatic, and there are side effects that are symptomatic. Many of you may take statin drugs, or may have taken them, may be familiar with some of these, but I'm just going to quickly kind of ramble through this list. Headaches, difficulty sleepy, flushing in the skin, muscle aches, drowsiness, dizziness, nausea, vomiting, bloating, abdominal pain, a lot of GI issues, rash, reduction in platelet counts, nausea, hair loss, pins and needle sensations, liver inflammation, pancreatic inflammation, skin problems such as rashes, sexual problems, etc. Myositis, we've seen people with myositis, inflammation of the muscles, which can have muscle breakdown, elevated CPK associated with inflammation of the muscle. Rhabdomyolysis is an extreme inflammatory muscle reaction. I've seen patients with rhabdomyolysis associated with statin drugs, and sometimes that can put your kidneys at risk, or put you at risk for kidney failure. And so you want to be aware of these problems. It could be particularly problematic in women, older people, people of small stature. If you drink alcohol on a regular basis, it could be a problem. If you have underlying kidney and liver disease, and many people with these comorbidities for heart disease or risk factors for heart disease who are candidates for statin drugs may have things like fatty liver, may have things like kidney dysfunction, because they also have high blood pressure and high cholesterol. And so it's not a free lunch, if you will. PCSK9 inhibitors. I'm just mentioning this because many of you may have been have had this discussed with you by your doctors. If you don't tolerate statin drugs, that these injectable agents, PCSK9 inhibitors, are what they're called. I won't call any brand names, but if you Google it, they'll give you the brand names. But what is a PCSK9 inhibitor? Basically, the LDL cholesterol receptor in hepatocytes, it binds to the particles, and the LDL receptors remove the LDL particles from circulation. PCSK9 is a binding protein, and it blocks, so it binds to the receptors and enhances LDL receptor degradation. And so if you block PCSK9, you block this binding of this binding protein to the receptor, and therefore you allow the receptors to be more available to remove more LDL cholesterol. So again, increased PCSK9 molecules results in decreased LDL receptors, which then results in increased LDL cholesterol particles. by reducing PCSK9, you're increasing the LDL receptors that and result in reducing the LDL cholesterol particles. So the injectable agents that reduce PCSK9, they're called PCSK9 inhibitors. They're currently available as adjuncts to statin drugs. If people don't tolerate statin drugs, or it's your maximum tolerance, and you can add a PCSK9 inhibitor with it to further reduce your LDL cholesterol. Statin drugs does not reduce lipoprotein(a). I'm going to talk about that in a few minutes, which is an atherogenic molecule. PCSK9 inhibitors do increase Lp(a), so lipoprotein(a). And so that's a molecule I'm just wanting to mention in the context of this discussion. It's not part of the main part of our discussion. There are natural ways of reducing PCSK9. I will mention that there's some natural agents, supplements that you can use that reduces PCSK9 that work as inhibitors in PCSK9. So how can you treat your lipids and inflammatory markers in a more natural way? The molecule, okay, what I want to do is mention, I should type this up somewhere, berberine, spelled berberine, berberine is a molecule that has favorable metabolic effects, and it's a natural inhibitor of PCSK9. So berberine, I want to, let me type that in. Let me type that and put that on the bottom of the screen here. Hold on one second. I'll put a little banner. Berberine reduces PCSK9 naturally. So I'm going to put that up there in a banner real quick so you can write that down. I think it's an important thing to know in the context of this discussion. So how can you do this naturally, though? We've done studies, and I've shared some of this data with you. And what I'm going to do is scroll down to our results. If you start individual, what we did in this study, it was a prospective study, but each patient was their own control. And there were 31 subjects, and I'm not going to go through the details, but we put them on a defined plant-based diet. It was essentially raw fruits and vegetables. And we looked at the overall outcome in this population of people by just going on a defined plant-based diet. So defined plant-based diet, most of this was raw. The foods were not heated up to above, say, 140, 150 degrees. And warmer, most of it was, at room temperature or below. There are lots of greens and the like. And what I'll do is I'll show you, let me just give you a screenshot of the foods that they consume. And so you look at the baseline and the final in terms of the servings of these different types of foods. So you can look at the changes. And so just do a screenshot of this, and it'll show you the reduction of certain types of food. So like total fruits increased by 800%, deep yellow vegetables, dark green vegetables increased by 500, 600%, respected, et cetera. White potatoes reduced by 100%, fried potatoes reduced by 80%, 95% reduction in grains, et cetera, 100% reduction in animal fat. So it shows you the relative change of what happened in this nutritional regimen, and how the food was prepared was also important. So that was the intervention. So what did we find? Well, I didn't highlight everything, but the total cholesterol was reduced by 16%. This is only in 4 weeks, by the way. Remember, the other trials showed 50% reduction in 2 years. We showed a 16% reduction in total cholesterol in 4 weeks, 17% reduction in LDL cholesterol in 4 weeks, triglycerides 16% reduction, HDL cholesterol. Now, the ratio of the good to the bad, even though the so-called good cholesterol was reduced, the bad cholesterol is reduced at a 2-to-1 ratio. And so the good to bad was reduced greater. And we always see a reduction in the HDL cholesterol, but the overall ratio of the HDL to total cholesterol improves. Now, here's what I want to show you. Lipoprotein(a), which is an atherogenic molecule, we were the first to show a significant reduction in this in nutrition in the medical literature. And it was a 16% reduction in only 4 weeks. Another group, shortly after we showed this, they showed a 10% reduction in about 5 or 6 weeks. They had more of a cooked plant-based diet, so it wasn't as strong of an effect, but still they also showed it. ApoB was reduced by 11%. ApoA was reduced by 14%. But what you want to do is you want to look at the ApoB to ApoA1 ratio, and you want to reduce that ratio significantly. And so what we did is we showed a 4.9% reduction in ApoB to ApoA1 ratio, which is important because that essentially correlates with good versus bad cholesterol. So that's the most important thing that we showed in that regard. Now, what did we show in other areas? Well, the C-reactive protein, as I said, went down by 30%, almost 31% in just 4 weeks. Now, they had a 37% reduction, but it took 2 years. So by just making a definitive change in your diet, you can reduce the C-reactive protein and inflammatory markers by just 4 weeks. IL-16 was reduced. Now, this is a cytokine that potentiates inflammatory reactions, which also potentiates heart attack and stroke and decompensation of heart failure. So inflammation through C-reactive protein and IL-6 cytokines were reduced significantly. The total white count was reduced, another marker of inflammation being reduced as an addition to other white counts. So the immune system was calmed down. That means that you had reduced inflammatory processes going on, and the biochemical fire. Maybe you hear me talk about inflammation as a biochemical fire. This biochemical fire was being put out or sequestered by the nutritional intervention alone. How about diabetes? Remember, the other studies showed an increase in report in diabetes. So the same study, and I'm just going to scroll down to the findings, and this is a different publication of the same data. And this talks about a food classification system. I want you to look at that. You can do a screenshot and study that in your spare time. And the title is on here as well, and you can look at that. But what did we find with, of course, they had weight reduction. There are many other benefits to this, a significant weight reduction, systolic blood pressure reduced, diastolic blood pressure reduced, medications were reduced. So there are many other benefits to this that I'm not really going into the details of. So you had an intervention that achieved the primary benefits that we were looking for in terms of cholesterol reduction, in terms of inflammation reduction. Now, we weren't powered to look at mortality, morbidity, or hospitalization, but we looked at these biomarkers, and we can correlate them with studies that did look at the biomarkers and did correlate them with mortality and the like. But what we saw here was that with this intervention, and even though these people were not diabetics, they had an average A1C that put them in a pre-diabetes range. We had a statistically significant reduction in hemoglobin A1C of about 3.4%, if you do that calculation, in addition to that 30% reduction in C-reactive protein. So we reduced inflammation, reduced cholesterol, reduced weight, reduced blood pressure, reduced medication, as well as reduced hemoglobin A1C. Now you say, well, hemoglobin A1C is an average of 3 months of blood sugar. Why did you show it in 1 month? The other thing that contributes to hemoglobin A1C is fluctuation in blood sugars. And so it's my hypothesis that it's the fluctuation in blood sugars that was heavily reduced here, and that had an impact on the A1C measurement. And so the point I want to make is that, the medications can be found to be effective, and there are lots of trials showing that statin drugs are effective, but they don't come without a cost. There are certain nuisance side effects. And then you look at the absolute risk reduction, the numbers are much smaller than when you're looking at the relative risk reduction, which is what you tend to focus on in these isolated studies. And so I just want you to be armed with that information, that understanding that, yes, there are actually more effective ways of controlling inflammation and cholesterol, which is through a defined nutritional regimen. And in addition to lowering these biomarkers, you're lowering inflammation, you're decreasing diabetes, you're reducing your weight, you're reducing your blood pressure, you're reducing your need for medication. Because remember, heart disease is number one cause of morbidity and mortality in the United States, cancer number two, medical treatments number three. And the overburdensome of too many pharmacological medications is likely a major contributing aspect of that medical treatment contribution to morbidity and mortality. So again, that's what I have for you tonight. Really thank you for your time and attention. I want you to give us a thumbs up. If you haven't done so, please share this information with loved ones. I think it's very important. Many people are prescribed statin drugs, especially if they have diabetes diagnosis or some other comorbidity for heart disease. Oftentimes they're just placed on the statin drug. I want you to, arm yourself with this information, pause and give some thought. One, am I going to have an overall benefit with this drug? Two, is there an alternative approach that I can dedicate myself to achieve the same ends or better without having to take this drug? And always take this into consideration when you're prescribed any drug. So again, thumbs up, thumbs up, thumbs up, share, like, and please share this information, because I think it's going to be very, very beneficial and informative to friends, loved ones, or anyone who you think can benefit. Until next time, keep it fresh, natural, and live.